Good morning, students. Welcome to my class, and I'm Dr. Rutusha Dodwad. Today we are going to talk about the management of macular hole. In our previous class, we've already brushed up a little on what is a macular hole and why is it caused. So now we are going to discuss about the management of macular hole. What is a macular hole? Would anybody like to attempt the question here? Any students? It's a small gap in the retina at the level of the macula, and this is an OCT imaging. The second picture that we see is a normal OCT image of the normal macula. We have seen and diagnosed the macular hole on an OCT. But what is the slit lamp examination which will help us to diagnose the full thickness macular hole? It's a good question, right? I want you to go back home and read up on this and tell me the answer tomorrow. This is a very nice diagram depicting exactly why a macular hole and how a macular hole is caused. First, there is vitreous condensation above the macula. There is vitreous traction, and there is centrifugal pull and centrifugal traction, which leads to gaping of these retinal layers, leading to the loss of the retinal layers at the macula. Anyone would like to attempt the staging of macular hole? Any guesses of how it's graded? Okay, I'll help you there. Stage 1 is basically a yellow dot that we see at the macula, and on OCT, it is the horizontal schisis of the retinal layers. In this case, we can always wait and watch. And we can also attempt another newer modality, which is the ochreplasmin injection. Ochreplasmin is a proteolytic enzyme. And how does it help us with the macular hole management if it's a proteolytic? Come on, guys, be interactive. How does ochreplasmin help us?
Release the reactant.
Yes, very good. Excellent. Smart kid. So anything beyond stage 2, which is a full thickness macular hole with or without a posterior vitreous detachment, we go ahead with the surgery. There are two main principles that we want to attempt with the surgery. First is to relieve all the tangential traction, that is either by removing the vitreous condensation, and second by the epiretinal membrane removal. And the second principle is to provide a retinal tamponade. We do it with the help of the gases, so that the anatomical apposition that we have attained with the surgery is maintained. Here we are attempting a 3-port pars plana vitrectomy, a 25 gauge. We are marking the port distance from the limbus at 4 millimeters in the phakic patient here. We do a core vitrectomy and stain the remnant vitreous with the help of triamcinolone acetonide. We see that around the disc there are white strands, and we are removing the posterior hyaloid attachment from posterior to the anterior, and making the we are exposing the internal limiting membrane that we are supposed to see that there is a blue color sheen. We are using a Finis loop to scrape off from where the vessels are there, because the ILM is least adherent at that point. After the flap is obtained, the initial flap, we take a forceps and do a maculorhexis. What is a maculorhexis? Just like a capsulorhexis. We do a tangential traction, a maculorhexis, and we go 360-degree around it. Usually a 1.5 to 2 diopters maculorhexis is done here. We do not pull it perpendicularly but tangentially. After we have achieved the maculorhexis, we do a fluid gas exchange, where we are maintaining the environment around the macular hole in a dehydrated state, and the apposition that we have attained of the macular hole gaping, we will tamponade it with the help of a C3F8 or an SF6 gas at the non-expansile concentration. As every surgery, there are a few complications here as well. First is the nucleosclerotic cataract, a later reopening of the macular hole, a peripheral retinal break, and a wedge-shaped temporal visual field defect, very rarely though. There are certain challenging cases in a macular hole surgery, which is basically the macular hole is chronic, non-healing, size greater than 300 microns. And in these cases, we have the advancements. I want you all to read up on advancements and come back in my next class. And anybody who does the 3 main advancements will get a Cadbury from me. Up for the challenge, guys? Yes, great. Thank you so much.
Very interesting presentation.
Thank you, sir.
What 2 important post-op advice that you like to give in a post-macular hole surgery?
Sir, if we are instilling the gas, we would ask the patient to lie in prone position for around 5